Good morning, ladies, gentlemen. Today we will start course of lectures of the second semester of your education at our department. Our today lecture will be devoted to following topic, which is topographical anatomy and operative surgery of anterior abdominal wall. Except this, I hope that we will talk about the science which study formation, development, conclusion, and treatment of hernias. Outstanding scientist, academician, Professor Stroverkov said that surgeon during performance of operation must put on the main task, saving of the life of patient, and look on following position: anatomical permeability, technical support, and physiological agreement. So, what is abdomen? Abdomen is a part of a trunk which rests between the diaphragm and entrance into the pelvic cavity. But in surgery exists another meaning of the abdomen, which means anterolateral wall of abdomen or simply anterior abdominal wall. My dear friend, during our lectures which I'll give to you, which I'll read to you, sometimes on the slide will be description firstly in Russian and second, of course, in English. Why? Because you must study Russian language, because very soon you will join to the clinic and you will need of Russian language for the communication with the patients. Orientation. Xiphoid process. It rests on the place of connection of the body with the xiphoid process. The level of connection of corpus sterni and xiphoid process is equal to the vertebra, thoracic vertebra number 9. Thoracic vertebra number 9. Costal arcs. They form by the 7th, 8, 9, and 10 costal cartilages. The lower level of costal arcs correspond to the 3rd lumbar vertebra. Iliac crest. This crest is possible to palpate. The highest point corresponds to the L4 vertebra. 5 cm laterally from the spina iliac anterior superior, possible to palpate iliac crest. Following formation corresponds to the 5th lumbar vertebra. Inguinal ligament, or another name of it is ligamentum inguinale. лігаменту інguinale or лігаменту по парті or latent tense cell лігаменту hypocrate. You know that sometimes according to a memory of this or that scientist, we give the name of a formation which was described by this scientist, name of this author. So, inguinal ligament, another name is Poe-Park ligament. But, I repeat once more, who first described it? And you know, the Hippocrates lived more earlier than Poe-Park. Hippocrates lived 24 centuries ago, and Poe-Park only 4 centuries ago. Why this ligament have two eponyms? Firstly, really the first person who described this ligament was Hippocrates. But at the time of the Hippocrates, I repeat once more, it was 24, even 25 centuries ago, all information was not printed, but usually written in manuscripts. The same story was with the inguinal ligament. When the Hippocrates described it, he put all information in a manuscript. All information in manuscript. But life is life and time is time. This manuscript was lost. And many centuries, more than 14 centuries after, Poe-Park once more described this ligament, and what is very important, and sometime after, archaeologists found manuscripts of Hippocrates, and doctors, medicals of all countries all over the world was under the very big problem what to do. To say the name of this ligament as a Poe-Park or put the name of Hippocrates. And finally decide that dominant name will be Poe-Park and additional name will be Hippocrates ligament. Hippocrates ligament. Pubic symphysis. Pubic symphysis. Pubic symphysis. Pubic symphysis is a hemiarthrosis. It rests in the median line between two bodies of the pubic bones. Medially from the pubic tuberculum rests pubic crest. You can see it, pubic crest. You can see it on the picture. Middle over inguinal ligament is a place where rests extend iliac artery, external iliac vein, and nerves. Here, deeply to the inguinal ligament, in the middle distance of it, rests external iliac artery, very big vessel. Finally, it's a dominant vessel for blood supply. Dominant vessel for blood supply over dominant vessel for blood supply over lower limb. External iliac artery continues as a femoral artery, and the femoral artery, as you know, it's a really dominant vessel for the lower limb, for the thigh, leg and foot. Superficial ring of the inguinal canal is a triangular shaped foramen in aponeurus of the external oblique abdominis muscle. In the male, it's a place where present spermatic cord, and in female, here rests round ligament of uterus. Round ligament uterus possible to palpate through the lateral part of the great apodendal ellipse, whereas spermatic cord possible to palpate through the superior part of scrotum by the tip of small finger, linea alba, linea alba. Linea alba is a fibrous formation. It formed as a result of a connection of aponeurosis of the wide muscles. External oblique abdominis muscle, internal oblique abdominis muscle, transverse abdominis muscle. It rests on the median line and rests on the distance between the xiphoid process up to the pubic symphysis. Up to the pubic symphysis. Umba is a hem in situ affixtions of the umbilical cord, which lies on a white line. It's another and maybe the most dangerous weak place in anterior abdominal wall or simply in abdomen for formation of the hernias. Semiludar line. It corresponds to the lateral margin of the rectus abdominis muscle that cross costal air on the level of the apex of ninth rib. Transpyloric plane. You can see it on the picture. The place of its location of this transpyloric plane is pointed by the red line. The place where we put this artificial plane is a place of projection of pylorus, gallbladder, duodenojejunal junction, body of a pancreas, helix of the left kidney. It means that if we decide to make surgical operation on following formations, anatomical formations, more easy to make it on the place where rests transpyloric plane. Next, if on abdomen, anterior abdominal wall, we will put 4 lines, 2 of them vertically. This vertical line will rest on the lateral side of the rectus abdominis muscle. Lateral side of the rectus abdominis muscle. And two horizontal lines, one line which connect costal arc, and another one which connect anterior superior iliac spine. Result of these four lines, two vertical and two horizontal, we will receive 9 regions, which called as regioepigastricum, regiohypochondrica sinistra, hypochondrica dextra, left and right hypochondric region. The umbilical region, and consequently left and right lateral regions, regiolateralis sinistra, regiolateralis dextra. Pubic region, regiopubial, regiopubial. And lateral to it, two inguinal left and right regions. What for we need to make these 4 regions? Because in each region projected some organs. And when the patient will come to you and will say that he or she have a pain in this region, in the epigastric region, first of all you will think about pathological changing, pathological problem with the stomach or with the liver or maybe with the duodenum, but you will not think about the rectum. But if the pain will be in the right inguinal region, first of all you will think about the inflammatory process in appendix vermiform. Next, if we will look on the abdominal wall from inside, we will see that on the median line rests plica, which forms the middle inguinal plica. It's here. It's pointed by the red arrow. It's a result of obliteration of urinary duct, urachus. Few words about this urachus. I hope that you know that what means urachus. Urachus is a duct, is a tube which connect urinary bladder and placenta. It's present in the fetal period of development. Usually 9th and 10th month of fetal life is supported by beginning function of the kidney. Kidneys start to produce primary urine. And of course, place where it will start is a urinary bladder. But capacity of urinary bladder is very, very small. And of course, it's not enough. It is not enough for whole urine which produced by the kidney. That's why from urinary bladder passes the duct which carry urine, evacuate urine from urinary bladder to placenta, where this urine successfully absorbed in the blood of mother. After the birth, urachus obliterate, closed. to it, present 2, another plica, intrinsic or medial, right and left inguinal folds. They represent the residual of the obliterate umbilical arteries covered by peritoneum. Covered by peritoneum. Covered by peritoneum. Result, we receive 2 medial folds. Next is lateral or external inguinal plica. It's here. It is here. Which is formed by covered inferior epigastric vessels. Result, between these 3 plicas, medial, median, medial and lateral, form 3 folds. Epigastric, medial inguinal and lateral inguinal folds. Medial is equal to the external ring of the inguinal canal, and this one, lateral, is equal to the internal or intrinsic entrance into the inguinal canal. Inguinal canal. Layers. First is the skin. Skin is movable. It contains over no big amount of the elastic fibers. That's why very easily can be tensed. Very easily can be tensed. Subskin fat formed normally contains over big amount of the fat. Here travel very big number of the arteries which communicate one with another. Anastomose. It's very, very important. Superficial fascia includes 2 layers. One is superficial layer and another one is deep layer or Thompson layer. Deeply to it present proper fascia. It covers muscles of the abdomen, external and internal oblique, rectus pyramidal and transverse abdominis muscle. External oblique abdominis muscle participate in the formation of the inguinal ligament. Internal oblique have external oblique and internal have opposite orientation of fibers. And the last one is transverse abdominis muscle. On the abdomen, rectus abdominis muscle, it's shown here. Rectus abdominis muscle, it can be seen here. Rectus abdominis muscle. Rests in the vagina which is formed by different fascias and aponeurosis. On the anterior abdominal wall, we can find 4 levels. 4 levels. Level number 1. It's a level of the xiphoid process. Anterior wall is formed by the aponeurosis of the external oblique abdominis muscle, and posterior wall is formed by the 5th, 6th, 7th costal cartilages and intercostal spaces. Superior to the arcuate line. It runs between the 2 lines which connect the most inferior located points of the costal earth. Here, anterior wall of vagina formed by full layer of the aponeurosis of the external oblique abdominis muscle and superficial layer of aponeurosis of the internal oblique abdominis muscle. Back to it, back to the rectus abdominis muscle, or by in other words, posterior wall of the vagina to the rectus abdominis muscle, formed by deep layer of the aponeurosis of the internal oblique abdominis muscle and transverse abdominis muscle. Transverse abdominis muscle. Inferiorly to the arcuate line, inferior to the arcuate line, anterior wall of the vagina to the rectus abdominis muscle, formed by all 3 aponeuroses. Aponeurosis of the external oblique abdominis muscle, aponeurosis of the internal oblique abdominis muscle, and aponeurosis of the transverse abdominis muscle. Posterior wall of the vagina to the rectus abdominis muscle formed by transverse fascia. My dear friends, I repeat once more to you that transverse fascia is a part of endo-abdominal fascia. Because this endo-abdominal fascia have different names in different parts of abdominal cavity. It depends near what muscle it rests. Near the transverse abdominis muscle is called as transverse fascia. Fourth, please. It's a point which rests superior to the symphysis. Here, anterior wall is formed by the aponeurosis of all 3 muscles: external oblique, internal oblique, and transverse abdominis muscle. Posterior wall of vagina is formed by the body of the bone. The body of a bone. Function of the muscles. Function of the muscle. External abdominis muscle, it's a flex to the lateral side. Rectus abdominis muscle, it's a flex trunk. Pyramidal muscle, it supports white line in tense position. And now I want to say a few words about the weak places. Weak places. Weak places on the anterior abdominal wall. Weak places on the anterior abdominal wall. Weak places of the anterior abdominal wall. Weak places of the anterior abdominal wall are, first of all, white line, linear elbow. On the level of the C-foot process here, width is around 5 to 8 millimeters. But on the level of umba, it rises, it's here more wider, and reach 24-30 millimeters. Then, inferior to the umba, it starts to be more narrow, until it will reach 3 mm on the level of symphysis. This place is a weak place because if the tonus will be decreased, here will form areas where will form hernia, will pass process of herniation. The biggest defect in the white line is the umbilical ring. Umbilical ring. Next. Second is the space between Spiegel line and external margin of rectus abdominis muscle. Number 3 is umba. Number 4 is inguinal space. Number 5 is a deep ring of femoral canal. Next, it's a supravesical fold, medial inguinal fold, and lateral inguinal folds. Blood supply. Blood supply is passed in 2 different layers. Superficial layers of the anterior abdominal wall is supplied by superficial epigastric artery. Arteria epigastrica superficialis. Then superficial circumflex iliac artery. Arteria circumflexa iliaca superficialis. And third one is external pudendal artery. All these arteries are branches, or simply originate from the femoral artery. Veins are tributaries of saphenous parva vein. Deep layers of the anterior abdominal wall is supplied by 6 lower pairs of the intercostal arteries. Anterior intercostal arteries, which are branches of the internal thoracic artery. Second group, it's an inferior epigastric artery, left and right one. Next, superior epigastric artery. Next is superior epigastric artery. All these 3 groups of the vessels, 6 pairs of the intercostal arteries, left and right inferior epigastric artery, and left and right on superior epigastric artery, make a very deep anastomosis between themselves. That's why even damaging one of these vessels will not occur formation of the terrible situation on the anterior abdominal wall. Blood supply will be still on the same level due to the presence of big amount of anastomosis. Veins drainage. From the anterior abdominal wall, blood drains by different ways. Exactly from the anterior abdominal wall, from the abdomen. Here, draining will be in superior epigastric. It's a tributary over superior vena cava. Paraumbilical veins, which join into the portal vein. And inferior epigastric, which is tributary over inferior vena cava. Finally, here on the anterior abdominal wall forms the anastomosis, which receives the name head of jellyfish. You can see it on the picture now. Sometimes maybe on the beach of the sea or river you can see a person who have a very big amount of the enlarged superficial veins on the anterior abdominal wall, which have the image over like a head of jellyfish. When we talk about the anastomosis of the porta cava anastomosis between the portal vein, between the superior vena cava and inferior vena cava, we must not forget that there are 6 anastomoses. And if artificially we will think about abdominal cavity like about a cube, we will see here 6 walls: superior, inferior, anterior, 2 lateral, left and right one, and 1 posterior. On each wall form anastomosis between the portal vein, superior vena cava, and inferior vena cava. Superior vena cava and inferior vena cava. Superior anastomosis is formed between the esophageal veins, which join into the superior vena cava, and left gastric vein, which join into the portal vein. Result: formation of porta cava anastomosis. Anterior anastomosis, we already talked about it not long ago, but I'll repeat to you once more. It's a superior epigastric into the superior caval vein, paraumbilical vein into the portal vein, and inferior epigastric vein into the inferior caval vein. Inferior anastomosis between the rectus, superior vein, superior rectal vein. It passes into the portal vein. Middle rectal vein, tributary over internal iliac vein, then common iliac vein, and then into the inferior vena cava. And inferior rectal vein join into the internal iliac, then internal iliac, then in common iliac, and then into the inferior vena cava. 3, and it's 2 lateral, left and right one, and posterior. They form 3 posterolateral anastomosis, which are always in formation of these 3 posterolateral participate lumbar veins. There are 4 pairs in number. Lumbar veins join into the inferior vena cava, anastomosis with the intervertebral superior vena cava, or lumbar veins anastomose with the veins of mesoperitoneal part of the large intestine. It's ascending and descending colic veins, which are tributary of the portal vein, and lumbar veins, it's an inferior vena cava. And the last one is the lumbar and ascending vertebral vein. Ascending vertebral vein. Ascending vertebral vein. Ascending vertebral vein. Lymphatic drainage. It passes into the anterior axillary lymphatic nodes. From the inferior to the ulna, it's a superficial inguinal. From the posterior region of the anterior abdominal wall up to the level of the iliac crest in posterior inguinal. From soft tissues, the rest inferior to the crest, into the superficial lymphatic nodes. Innervation. Innervation is due to the primary ventral rami of T6, T7, T8, T9, T10, T11, T12, and also iliohypogastric and ilioinguinal nerves, which are branches of the lumbar plexus. Next, requirements to sections. First of all, section, incision, cutting must be on the proximate distance to an organ. Must be the most short distance between the incision, between the section, between the cutting and the organ, for making of more smaller amount of the traumatic damaging of the tissues. Second, it must be sufficient length. What I mean? If you will make very big only big cut, is accompanied of additional trauma to the soft tissues. Of course, post-operative period of rehabilitation will be very, very long. If you make small one, to the surgeon will be very difficult. Very difficult to make this surgical operation. Incision must be small trauma. It must be minimal trauma of the nerves, vessels and soft tissues. Length and the direction depends on the position of the nerves and vessels of the anterior abdominal wall and orientation of the muscular fibers. Aponeuroses. To make more smaller trauma. Next, the section becomes a long folds of the skin, which causes formation of a tender and thin scars, hence, in the post-operative time. If the scar is rest in this fold, it will be nearly invisible. Perpendicular cutting usually concludes formation of the rough keloid scar, keloid hand. But sometimes surgeons are forced to react, leaving medical indication instead from cosmetic, to make transverse section, transverse incision instead to make longitudinal. Incision of 1-2 segmentary nerves in leads of paralysis and dystrophic to change of musculation of frontal-lateral walls of a gaze and segments of the rectus muscle. It is accompanied by the indulgence of the abdominal tonus and support the visceral ptosis, sometimes formation of abdominal hernias. Next, access to the organ between the nerve trunks is due to the trauma of the muscular fibers. If we do this between the nerve trunks, we will not damage nerve trunks. Of course, muscles in post-operative time will function normally. All sections of the anterior abdominal wall can be divided into straight, vertical and horizontal. Straight, vertical and horizontal. Straight, vertical and horizontal. Straight, vertical and horizontal. Next oblique. Next oblique. And combine. And combine. Medial laparotomy with the cutting of anterior abdominal wall on the medial line can be divided into the superior, middle, and inferior. Positive. This cutting is small trauma. Bleeding, hemorrhage not exist in general because very small amount of the arteries are here. Not cut nerve trunks and muscle fibers. But what is negative? Regeneration of the connective tissue, and here in the white line present connective tissue, as you remember. Usually continues very long time, and this time is counted not by the hours or days or weeks even, but by months. Here amount of the blood vessels are very small, and regeneration of connective tissue is also very long. Very long. And even sometimes it occurs in formation of hernia. To the straight vertical also we can put paramedian, superior to umbilicus and inferior to umbilicus. Then pararectal from the lateral and medial sides of the rectus abdominis muscle, and transrectal incision through the muscle. The last two incisions are very traumatic, but post-operative hernia after such operation is impossible. Regeneration passed very, very quickly. Really, hemorrhage big, trauma big, regeneration fast, and hernia impossible. The straight horizontal usually provides horizontally parallel to the elastic fibers. The well-known are two, which are Winkelmann, Pfannenstiel, and Czerny approach. And Czerny. Oblique usually made into the epigastrium and hypogastrium, mainly Volkovich-Diakonov through the Magburny point. And oblique are very nice, especially because possible to continue it if need. Combined thoracoabdominal, usually traumatic, but give a chance to make examination of very big amount of the organs, including organs of thoracic and abdominal cavities. Next, if we will make a cutting of the anterior abdominal wall on the median line, so we will pass following layers. First it will be skin, then subskin fat, then superficial fascia, then proper fascia, then linea alba, then transverse fascia and extraperitoneal fat. And finally will be parietal peritoneum. Attention! What for we must remember this? What for I accent your opinion on this? Because we entrance into the abdominal cavity by passing of skin, subskin fat, superficial fascia, proper fascia, white line, transverse fascia and extraperitoneal fat, and parietal peritoneum, which join inside of abdominal cavity. But when we exit, when we finish our operation, we will need to connect layer to layer parietal peritoneum from the left side to the parietal peritoneum of the right side, and not transverse fascia with the parietal peritoneum. They will not regenerate between themselves. And here we'll form the window, artificial window, and it will be a good place, a good gate for future hernia, hernial gate. And if we'll do this cutting on the lateral or inguinal region, laterally to the inferior epigastric artery, it will pass the same skin, subskin fat, superficial fascia, proper fascia, aponeurosis of the external oblique muscle, it's a new, internal oblique muscle, new, transverse muscle, new, transverse fascia, extraperitoneal fat and parietal peritoneum, the same. And finally, I want to accent on and put some the time for repeating of the walls of the inguinal canal. Inguinal canal, you studied it last year, twice. Once when you study muscles, and once when you study male and female genital organs in the studies of the course of anatomy. But sometimes we see a student who don't know where is the Arduino kernel and how it formed. Try to remember that Arduino kernel contains of 4 walls. They are anterior, posterior, superior, and inferior. Anterior is formed by the upper walls of the external oblique abdominis muscle. Posterior wall is formed by the transverse fascia. Superior wall, attention, formed by the margins of the intern oblique abdominis muscle and transverse abdominis muscle. You see, formed by the muscles. And inferior is a inguinal ligament. What it contains? In male, it contains ova spermatic cord. In female, it contains a ligamentum terasutory. Femoral triangle. Femoral triangle is bounded by externally sartorius muscle, internally adductor longus muscle. Height of the femoral triangle is 15 to 20 centimeters. Floor of it contains of the deep triangle or pit, fossa iliopectinea. Walls of each are musculus iliopsoas and musculus pectineus. And now, my dear friends, herniology. I know that you are very tired. There's a small brick, not brick, and I want to put some information to you which is very important and recall it. My dear friends, please don't forget that after each lecture, chief of the group must collect screenshot of the students' presence on the lecture. Each student must not only make screenshot but also entitle this screenshot by his or her name in Russian, like it written in the papers of the dean office. And not nickname. If full name is Abhishek Kumar, you must write Abhishek Kumar, and not only Abhishek and not only Kumar. Better if it will be entitled by the Russian. Then you will give to the chief. Chief will put it in one folder, entitle it, zip it, and send it to the chief of the division. And the chief of the division, my dear friends, he or she will send it to me. Let's make agreement. Lecture is today. Not later than today, afternoon or evening, not later than evening. You must send it to me. You know my email. All chief students know my email, and please send it to me. If this or that group will not give information about presence, I'll put to whole group absence. Of course, it will not stop you. It will not stop you in receiving permission to give module exam, but influence it will make, believe me. Second, it's special to the students of my group. Before the summer vacation, I gave to students scientific summary report topics. I received only 2 presentations. The rest students did not do anything. My dear friends, if I will not receive it during 2 weeks, it means that on the 1st of October it will be a deadline. If I will not receive prior for primary checking, trust me, I'll delete this topic and will delete the family name of the student from the member of future conference. It's a second. Third, some students still not clear first, second or third control points of previous semester. My dear friends, don't make monkey's business. Try to do everything very, very quickly. I already told to you. Of course, maybe you not believe, still not believe, but trust me, it will be. And when it will be very, very late. If you will not pass even one control point positively, result, final exam, you will not pass. My dear friends, I don't want to scare you. Now, time for work. I live not so far from the Gagarin Park and see very interesting situation sometimes in the evening. First of all, I'm surprised, really surprised. I didn't see before when one Indian girl in the evening, in the night time, travel with Indian boy and hook each other. I didn't see it. Just now I see. I see many, many students in the park. Boys, girls. Sometimes behavior of them is not nice. Look, you live in this country now. This country has some tradition. And this is not equal to tradition of India. You cannot put the feet on the branch on which you sit. You cannot cry and some another. Don't forget, all people around look on you and think that all India the same as you. It's a first. Second, no, but main part of the students have very good behavior. Very good behavior. I can't say any one word. Second, my dear friends, enough to rest. Start to work. And number three. If you have some problems, please be so kind, clear it with your previous teacher. If your teacher changed, go to the previous teacher and try to clear all your non-given control points. Try to do this, everything is very, very quickly. If you will not find a decision, come to me and I'll try to help you. Okay, herniology. Herniology is a science which studies formation, development, conclusions, and treatment of hernias. First description of the hernias was made in manuscripts of ancient Egypt. These papyrus have own name, Erbes. It was written 15th centuries before Jesus Christ's birth. In the 4th century before Christ, outstanding ancient Greek doctor Hippocrates describe hernias. But firstly, term hernia was inputted by the Celts in the 1st century after Christ. And it first described hernia as a projection of the organs through the artificial gates. And Celsus was the first doctor who decided to discuss the question about the hernias as a part of surgery, as a surgical pathology. Surgical pathology. Operative methods of treatment of the hernias of that time was very, very terrible. And even treatment of the hernias provided not by the doctors, but the hair makers, hernia sac, hernia cutters. It usually supported by the profuse hemorrhage, by infection, trauma, necrosis, for the closing of the gate, usually used treats, which is made from the gold, silver, iron, copper. For cutting, used needles which made from the wood and iron. Make injection of the iodine, seawater, and concentrated of alcohol. But positive result was not existed. All this continues up to the end of the 19th, beginning of 20th century, where an outstanding Italian surgeon, Bassini, he lived in 1844-1924. He made one common conception of surgical treatment of the inguinal hernia. Of course, after that was formation of new biomaterials, polyester, polypropylene, polytetrafluoroethylene, and some another materials for reinforcing of the walls of the hernia. Classification of the hernia. All hernias can be classified into the external hernia and internal hernia. External hernia consists of three main parts. These parts are hernial gate, hernial sac, and hernial content. Hernia abdominalis externa contains of three parts: gate, sac, content. Internal hernia, it inserts into the opening over the peritoneum and rests inside of peritoneal cavity. It contains of only two parts: gate, content. Sac not exist. Sac not exist. External hernia, according to location, can be divided into the following: inguinal hernia, direct and indirect, straight and oblique. Second, femoral hernia. Third, hernia of linea alba, epigastric hernia. Number 4, umbilical hernia. Number 5, hernia of Spigelian line. Hernia of Spigelian line. Number 6, lumbar hernia. Number 7, obturator hernia. And number 8, postoperative hernia. Internal hernia. As you understood and as you remember, I already told you about it. Hernia sac is absent. In internal hernia present only hernial gate and hernial content. To the internal hernia belong hernia of the duodenojejunal recess, hernia recessus duodenojejunales, omental bursa hernia, hernia bursa omentalis, retrosacral hernia, hernia retrosacalis, and the different types of diaphragmatic hernia. To the rare abdominal hernia belong hernia subsequent process of sternum, hernias of the spigal line, or semiludnar line, hernias of the umbilical cord, lumbar hernias, perineal, ventral and dorsal hernias, obturator hernias, and sciatic hernias. All these rare hernias are shown just now on the screen. Hernia umbilical cord, lumbar hernias, perineal ventral hernia, obturator hernia, and sciatic hernia. According to etiology, we can describe congenital hernia. Usually this hernia formed during embryonic and fetal period of development. Received hernias, Goth hernias, which is after the birth. Number 3, postoperative hernias. Next, recurrent hernias. And traumatic hernia. According to clinical, reponibal hernia, when hernial contents freely exit from the abdominal cavity and very easy return back. Second is in reponibilis hernia. It usually contains over connection of hernial content with the wall of hernial sac and inability to return back. But what is important? Not exist incarcerate hernia. And the next group is a incarcerate hernia, where hernia contents pass in the hernial sac and cannot return back назад. Here formed edema, more bigger pressing in the hernial gate, hypoxia, ischemia, necrosis, and perforation. Besides the incarcerate hernia, we can describe Richter or Coles wall hernia and retrograde hernia. It's shown here, where the pressed part of the hernial content rests inside of abdominal cavity. Sliding hernia. Here, hernial sac is presented by the wall of cavity organ, which is not covered by the visceral peritoneum, like urinary bladder, cecum, or sometimes in other organs. It can return back in abdominal cavity. Main principles are in elimination of hernial content and plastic strengthening of the weak place of the abdominal wall for prevention of the relapse of the hernia. What stages of surgical operation of treatment of the hernia exist? First, level by level dissection of the tissues over the hernial protrusion according to anatomical region. Second, dissection of hernial gate. Number 3, allocation hernial sac. Number 4, dissecting of sac and revising of its contents. Number 5, bandaging and cutting of the pouch and its neck. And number 6, plastic closure of the hernial gate. Plastic closure of the hernial gate. There on the picture is shown some stages of the surgical operation. Next, what I want to tell you, it's a elastic infringement and very narrow hernial gate. It's the causes of the infringement and its types. And here is a focal infringement. Retrograde infringement. Infringement of the wall. What sign of the restrained hernia exists? First is pain. Second, non-set hernia. Third, strain and morbidity. Strain and morbidity. And absence of the cuff, push syndrome. When you put the finger in the hernial gate, and propose to the patient to a coffee. If here will be restraining, the finger will not able to exit. Of course, we must check. How about colon? Is viable gut or not? If we take a colon and put it in 0.9% solution of the natural chloride and covered by the tissues, you will see that color change on the pink from the green, gray, color change on the pink. Its hypostasis decrease. Serous layer start to be smooth and shining. Past peristaltic reductions and peritoneum pulsing of the vessels. So it's very good. It means that viable gut. But if non-viable gut, cyan crimson color, sometimes black-green color, no pulsing of the vessels, and no reduced. In these cases, obligatory must remove it. Approximately 30-40 in proximal part and 20-30 in distal part of small intestine must be removed. A few words about the GN hernias. This GN hernias of patient. Very difficult to understand size of it. It's very, very big. Because look very, very carefully. This is a thigh, this is knee, and this is leg. Look on another image. It's abdomen, and this is hernia. It's a hernia in sitting position of the patient. Patient was invalid, was not able to do anything by himself. Even walking was impossible to him. Look, computer tomography. Size of hernial gate. Size of hernial gate, look, 9 to 8 to 7 centimeters. Very, very big. It's a hernial sac. This is fluid in hernial sac. Capacity of the fluid 14.3 liters. 14.3 liters, you see how big, very, very big. After surgical operation, 6 days, 4 months. Patient start to work, everything is nice. And another one, it's a hernia of the anterior abdominal wall. Hernia of anterior abdominal wall. After treatment, after section, you see, through whole anterior line was made a section, because need to make examination of many, better to say all organs of abdominal cavity. After operation, 15 days after operation. My dear friends, in general this is all. Thank you very much for your attention, cooperation, patience. If you will have some questions, please be so kind, write it on the chat, on the wall, but obligatory write your name and group number, because I must make answer to some to whom I will make the answer. Thank you very much. See you later. Goodbye.